speaker, Dr. Zayba Noor, who did her bachelor's from G. Pullareddy Dental College and currently pursuing her master's in OMFS at KLE Dental College, Bangalore. So as we all know now that today's topic is to learn more about initial management and initial management of trauma cases. So some of us might wonder as why this topic today, or how is it gonna benefit general dental practitioner? We all in our day-to-day life do come across road traffic accidents or assaults or beat any trauma in that case. So this spectrum of these injuries could either range from only minor injuries, which are specific only to the soft tissue injuries, or it could be as severe as life-threatening injuries. Especially in maxillofacial region, these life-threatening injuries can further complicate the management of these patients due to concomitant injuries to either head or airway or the cervical spine. I am sure we might have come across this term called golden hour, which is considered to be the crucial time in the management of these trauma patients, beyond which the morbidity and mortality of these patients will further complicate. So now let's move on and see more in depth to this topic. I request you, Dr. Zayba, to take over the podium and enlighten us more about this topic. Over to you, Dr. Zayba.
I'll start sharing my screen.
Yes, sure.
Assalamu alaikum everyone. So today I'll be starting about my topic on initial assessment of trauma and primary care. So as we all know, we like most of us use the public transport and many other ways of transportation, wherein we can come across many people who meet with an accident, let it be a pedestrian or a driver or a rider. So if at all we come across any kind of a person who has met with an accident and just see any kind of scenario in our day-to-day life, so this is something which is about the emergency care which has to be given to that particular patient at that particular point of time to save his life. So today's contents about the topic would be first of all about the trauma and its statistics, and then the scoring of the person's severity, the primary survey, that is about the primary assessment, what all care has to be given to that particular person in the at the earliest time, and then the resuscitation of the patient, and followed by the secondary survey. So what actually is trauma? Trauma is nothing but any kind of an accident or mishappening which can be due to either assault or some sport or some war, or it could be because of any road traffic accident. But most of it, what we see is because of the road traffic accident, which comprises of 22.8% of all the or of all the injuries a person succumbs to. And other reasons could be either due to because of poisoning or any drug abuse or suicide or any violence or any kind of personal assault. So according to the American College of Surgeons, according to the American College of Surgeons, first thing what we need to do is the patient's preparation to transport him to the earliest to the hospital at the earliest. So then the primary survey and resuscitation of the patient is done, wherein the patient is monitored and the required radiograph and other investigations are conducted. Later, the secondary survey is done, wherein after the primary evaluation and management of the patient, the secondary management is done. That is, which all do not come under the emergencies, that is counted under the secondary survey. And then re-evaluation of the patient is done. That is the primary evaluation, again re-monitored, and then the secondary evaluation re-monitored. That is the various protocols which are being done already. It is re-evaluated and followed by the definitive care so as to stabilize the patient. So of all the traumatic injuries succumb to any kind of person because of any reasons, most of the injuries, which are like 5% of the injuries which a person gets, 50% of them can lead to his death of like the severe injuries. And there are injuries which are urgent, which can be addressed and can be managed. they are about 10 to 15%. And other the injuries which comprise the major chunk, that is the 80%, are the non-urgent injuries, which can be delayed but has to be addressed at the earliest. So first comes the pre-hospital phase, wherein the patient has to be transported and the necessary requirements for the patient's transport has to be done, like the call for the ambulance and the paramedics, and then informing the hospital about the status of the patient, the number of victims, and also the status of how well the patient is doing and what all are the things required for the patient stabilization. And if at all any ventilation or any emergency care is required, that also has to be informed to the patient, to the hospital authority, so as to keep everything ready before the patient arrives the hospital. Then comes the golden hour. Golden hour is nothing but the first 60 minutes after the trauma, wherein the patient like survival is decided. If most of the management is done within this 60 minutes of the period, then there is more survival rate of the patient. If at all this golden hour is passed, then the survival rate keeps coming down. And they say that every hour, every passing hour decreases the chances of patient survival by 20%, and every hour counts like 40%, 60%, and so on. Then comes the triage, which is the color coding of the patient depending on his severity. Red is for the emergency care, wherein it is like the immediate care which has to be taken. It could be a life-threatening because of any damage to the limbs or any major organs, wherein there could be multi-organ failure or any limb injury, wherein there is major blood loss, and it has to be addressed immediately. Otherwise, it could be a life-threatening scene for the patient. Yellow is urgent, but little bit of delay here and there can be considered. So it could be because of the significant injury or illnesses which can be delayed but can be tolerated again. The green is the non-urgent, which are like the minimal injuries which can wait for the treatment, such as like soft tissue injuries where there is no major blood loss. And black is the one wherein we put the situation wherein the patient either has passed away or he is at the stake of expiring. So most of the times no treatment would be required, not to put the patient to any kind of situation. Or if he is expected to survive, then whatever the minimal treatment is required to get him from the black zone to the red zone is given, so as to stabilize him first, and then later giving the treatment according to the severity and his injuries, what he has got. Then comes the start system, wherein we evaluate the vitals of the patient. First thing is we check for the respiration. If there is no respiration, then there is no point of proceeding further, and he is directly tagged as black. And if at all the respiratory rate is more than 30 minutes, that is, he is hyperventilated and there is no radial pulse and he does not respond to your commands, then he is put into red zone and he is considered as the urgent person to be addressed. And then next comes the yellow zone, wherein he is rated as 2, wherein he either has injuries which are not to be addressed very urgently, but still it has to be addressed at the earliest. And then comes the 3, that is the green zone, which is the safest zone. And with very minimal treatment or no treatment, the patient can just walk away. So first thing is once the patient has arrived to the hospital, then the primary survey is done. That is the ABCDE, which I'll be discussing further in my coming slides. And then after, if ABCD is done, then it is reassessed, and then the secondary evaluation of the patient is done, followed by the definitive care. So the ABCD is nothing but the protocol which has been followed in stabilizing the patient's condition. A stands for airway, B is the breathing, C circulation, D is the disability, and then E is the exposure of the patient to the environment. So according to the patient's response, we rate the severity of the patient depending on the Glasgow Coma Scale, which was given by Janet and Teasdale in the year 1974. Later, he had revised it in 1976. So depending on the injuries attained by the patient, we try to assess the patient's stability and his consciousness. So three things are evaluated, which is the motor response, the verbal response, and the eye opening. So if the patient responds immediately to your commands, he is rated as 4, which is the best. And if he doesn't respond, it is the worst, that is 1. And best motor response, that is the patient's response immediately to the command, is 6. Then when he is localizing towards the pain, he is 5. And then if at all he is not responding at all, then it is rated as 1, which is the least score. And the same way, verbal command is also evaluated, wherein if the patient is very well oriented, he is rated as 5, and he does not respond at all, then he is rated as 1. So the highest score injury is more like towards the mild head injury, like more stability. So lower the score is the less stability of the patient, which indicates towards the severe injuries, and he is more emergency, like he needs the more emergency treatment. This protocol of Glasgow was updated again in year 2020 with the normal terminology, but there is no much difference as such. Then this is for the children, wherein the best motor response is rated as 2. And when the patient withdraws it towards the painful stimulus, it is rated as 1. And if there is no response, 0. And the similar way, verbal command and the eye movement are evaluated. Here we do not go into very specific response, because the brainstem is still establishing in the cases, or in the case of children. So once the whole brainstem and the nervous system is established, he's an adult, that time we apply for the adult scale, and until then this comma scale for children is followed. Then comes the injury severity score, wherein we evaluate for the injuries which is which the patient has got. So if the injury is very minor and can be addressed, or it can be left without any treatment, it is considered as 1. And if it is very severe, which cannot be treated, and he is considered as unsurvivable, it is considered as 6. So the major score and the minor score are put together, and then the top 3 in major injuries are squared, and then the score is attained. So if the score is above, it is scored in between the range of 1 to 75. So depending on this, we decide the treatment for the patient. And then comes the revised trauma score, wherein you look for the patient's blood pressure and the respiratory rate, and then also the revised trauma score is calculated accordingly. So here, more the Glasgow comma scale, that is like less the severity of the patient is, so the blood pressure also will be falling under the normal limits, and the respiratory rate will be normal. So the revised trauma score will be rated as 4. And if the Glasgow comma scale is least, that is there is no response in the verbal command, motor command, and also the eye movements, then it is like very least blood pressure or no blood pressure. And if there is no respiratory response from the patient, then the RTS value is considered as 0. Then comes the airway maintenance, which is like the first protocol and the very important part, wherein we need to establish the patient's airway to stabilize all other systems of the body. So any patient we come across who has come across a trauma, he has to be considered as a patient who has succumbed with a cervical spine injury as well. Until unless we don't confirm that he has got a cervical injury or not, we need to consider him that he has got a cervical spine injury, and we need to handle him accordingly. So there are more chances of cervical spine injury when there is a high speed impact, and also in 15% of the patients with supraclavicular injuries and 5% of the head injuries have an injury to the cervical spine. And then we need to check for any obstruction in the airway. It could be because of any aspiration of any foreign bodies, or due to any injuries which has caused the dislocation or fractures of any of the facial structures wherein there is obstruction to the airway, or any tongue positioning, or because of any internal bleed. There could be any clot or embolism which would have obstructed the airway, or any other foreign agents which could cause the obstruction. So this has to be looked for, and then the obstruction has to be removed. Then later we have to look for the patient's response to the airway. So if the patient is able to talk, then you just proceed further with the ABCDE protocol. But if the patient does not respond to the command, then you have to look, listen, and feel. Look for the patient's movements. That is, we look for the chest movements, and we look for the eye movements. If the patient's chest movement seems to be abnormal or agitated, it means the patient is under hypoxia. So that the immediate airway has to be established in such cases. And also the patient's the position of the trachea has to be felt. If the patient has any obstruction in the airway, there could be little drift from the midline. That is, the trachea would be moved towards the left or the right. And if the airway is stable, then the trachea can be seen to be positioned in the midline. Next comes the airway management in the cases of choking. So if any foreign body is suspected during the examination, then the foreign body has to be immediately removed so as to prevent the airway obstruction. So there are different maneuvers which we follow in different kind of patients. In a normal adult, we can just follow the Heimlich maneuver, wherein we give five like the patient is just given a 5 pads on his back 5 times, and then we give 5 abdominal thrusts. So if the foreign body is expelled, then the airway is just evaluated again, but there is no expellation of any kind of foreign body. Then again 5 more abdominal thrusts are given in the cases of adults. But in the case of kids or infants, the chest thrust has to be given, and the back blows have to be given by holding the kid or the infant in an inverted position, upside down. But in the cases of pregnant ladies, the abdominal thrust is not given, and wherein the chest thrust is given just above the abdomen, and then followed by the normal protocol. Then once any cervical injury is examined or suspected, or if at all any kind of immobilization of the patient is required, then we need to use various things like cervical collars or any semi-rigid cervical collar with a head block and tape so as to stabilize the patient's spine. Then for the establishment of the airway, there are various procedures such as a jaw thrust or chin lift, wherein in jaw thrust, the knuckles are placed, knuckles of the index fingers are placed behind the angle of the mandible, and then the thumbs are placed over the cheekbone, and then both are compressed at the same time so as to move the mandible forward. If at all there is any obstruction in the airway, then with the jaw thrust or the lifting of the mandible forwards, then the airway is cleared. And once the breathing is established, then high flow oxygen via a face mask has to be placed. But if there is no breathing, or the patient is not breathing on himself, then a ambu bag can be used to establish the airway, and it has to be pumped manually. This is another procedure wherein the chin is lifted, wherein the mandible is gently lifted upwards using the fingers of one hand, and it is placed under the chin. The thumb of the same hand is used so as to depress the lower lip and to open the mouth and to check for the airway. So this is the flowchart wherein it's a summary of the establishment of the airway. If there is any cervical spine injury suspected, just look for the patient's oxygenation and ventilation. If there is breathing, then there is nothing to be done, and orotracheal and a nasotracheal intubation can be done. Or if the patient is, if the doctor is unable to intubate the patient, then any pharmacological adjunct can be used and orotracheal intubation can be done. If that is also not possible, then surgical airway has to be established. But if there is no breathing at all, then without a wasting of any time, orotracheal intubation has to be carried out. But if this is also not possible, then surgical airway has to be established. So various airway maneuvers and adjuncts. So the once the patient is like checked for no kind of breathing and all, then the oropharyngeal airway has to be established. This can be done with the oropharyngeal airway, wherein we first we check for the air, we retract the tongue and then look for the larynx, the trachea, and then the patient is placed upside down, and then the device is rotated at 180 degrees to face the concavity towards the tongue, and then it is slipped to retract the tongue forwards. Then another way of establishing the airway is the nasopharyngeal airway, wherein the airway tube is placed through the nostril of the nose. So the length of the airway can be calculated by estimating the distance between the nostril and the earlobe. So once the distance is determined, then using a tube through the nostril and lifting the patient's chin upwards, with the help of a laryngoscope, the cords can be visualized, and then the tube is placed so as to pass the tube through the nostrils into the trachea. Here we need to check for the patient's reflex. If there is a reflex or gagging, that means the tube is in the right path. And another airway management way is the laryngeal mask airway, wherein the laryngeal mask can be used, and then with the help of it, the airway can be established. This is the like ambu bag or the big valve mask which is used with the air ambu bag, and then the oxygen is pumped out manually. So here we come across one more chart wherein the concept is called as lemon. Lemon is nothing but we look for the external signs wherein the patient shows the signs of airway or if there is apnea, and then we evaluate which E stands for, and M stands for the Malampati scale. That is the positioning or the visuality of the uvula when the patient opens his mouth to the maximum, and then any obstruction, and the neck mobility. So when looked externally, we look for the patient's signs. If the patient's face looks to be normal and there is no deformity in the neck or any positioning of the trachea, then the airway difficulty is less. But if the patient's face is abnormal or sunken cheeks, or the patient is edentulous, or he has a receding mandible or a narrow mouth or obesity, and this could be because of the short neck, then the establishment of the airway is little difficult when compared to that of the normal person. Then evaluation is done with a 3-3-2 rule, wherein the mouth opening has to be at least 3 finger wider, and the distance between the chin and the hyoid bone has to be 3 fingers, and thyroid cartilage to the mouth floor has to be 2 fingers. If it is lesser than this 3 and 2 rule, then that becomes more difficult for the person to intubate. Then according to the Malampati scale, so this is the visuality of the uvula when the patient tries to protrude his tongue outside. So if it is the maximal visuality, then it is scored as 1, which is the best. And with the limited visuality, it is 2. Like minimal, like reduced visuality is 3, and no visuality is 4. Then this comes with the oroendotracheal intubation, wherein suction tools for the intubation has to be done, and oxygen positioning of the patient is very important, and then monitors, whereas the pulse, BP, and other leads for the electrocardiography are connected, and then patient with the ready face mask and ambu bag has to be like by the side of the patient, and then IV access has to be established, and any drugs for the pre-treatment of the patient's stability has to be done. So the rapid sequence intubation is first patient's preparation, pre-oxygenation, that is trying it with the manual oxygen pump, and then pre-treatment, then paralysis with the induction, then protection, placement of the tube, and then intubation of the patient. The complications of intubation could be any trauma to the mucosa or dislocation of mandible, any trauma like wherein there is any intraoral trauma or fracture of the teeth or anything. While placing the tube or the laryngoscope, there could be some mobility of the teeth or the avulsion of the tooth. And then esophageal intubation, it can cause any infection or any other injuries like any other internal injuries. If at all the manual establishment of airway is not possible, then the surgical airway, that is a tracheostomy or cricothyrotomy, are carried out. So first comes the cricothyrotomy, which is done with the needle. So insertion of a wide bore needle via the cricothyroid membrane into the airway is established, and then it is done with the intermittent insufflation, that is 1 second on and 4 seconds off. Then the maximum time to be done is 30 to 45 minutes, and it is done in cases of inadequate ventilation. So this is the procedure wherein a cricothyrotomy is carried out. First, the cricothyroid membrane is palpated, and we have to advance the needle at an angle of 45 degrees, and with a syringe with a saline is aspirated to check for the air bubble. If the bubbling of the saline is seen, then it means the needle is in the right position. And then in that same position of the needle, a catheter is for advanced, and then with the use of a guide, the airway is established, and the cricothyroid tube is inserted into the cricothyroid membrane so as to establish the airway. So this is a summary of the procedure of the cricothyroidotomy. So it is contraindicated when there is complete or partial transaction of the airway, if there is any injury to the cricoid cartilage itself, and if there is any severely fractured larynx. And in young children, cricothyroidotomy is usually contraindicated because of the size of the membrane and the narrow pediatric airway. Next comes the tracheostomy. It is indicated in the laryngotracheal trauma, and if the cricothyroidotomy is contraindicated, then we can go ahead with the tracheostomy. It is done when there is prolonged ventilation is required and upper airway obstruction is already present. So here the position of the patient is done with the shoulders elevated by a sandbag, and then the main landmarks which are checked here are the suprasternal notch, and then the thyroid gland and the cricothyroid membrane. So usually these landmarks are located, and then once the thyroid cartilage is it is marked, then the trachea is stabilized with the hooks, and then vertical incision is placed. And then once the incision is placed, we come across the platysma and the other strap muscles. These strap muscles and the platysma are retracted upwards. And then we come across major vessels such as the anterior jugular vein. So any vessels coming across have to be retracted and safeguarded. And then once the muscles are retracted and located, then we come across this cricothyroid membrane. Then another vertical incision is given. The first incision was the horizontal incision, and now we go with the vertical incision. And then once the vertical incision is given, then the tracheal rings are visualized. So once the tracheal rings are visualized, in between second and the third ring, the needle is placed with a saline and then aspirated. The similar way which we had conducted in the cricothyroidotomy procedure. So if the bubbling is seen, then the tracheostomy tube is inserted and it is secured to the adjacent soft tissue with a suture. And in case of any collection of the fluid or any CSF collection, then the chest drains are also placed for the emergency management. So for the placement of emergency for the chest drain, there are the 4 landmarks which are important. That is the base of the axilla, the lateral edge of the pectoralis major muscle, then the 5th intercostal space, and the lateral edge of the latissimus dorsi. So these are the 4 landmarks which make the area of the placement of the chest drain. So if there is any collection noted, then in this area the surface has to be marked, and then placement of the tube has to be done to allow the drainage of any collection of the fluid. So there could be any massive hemothorax after trauma. So there is rapid accumulation of more than 1500 ml of the blood in the chest cavity, or damage to the great vessels, or dull percussion note, or hypovolemia. These are the signs which are noted when there is any massive hemothorax. So this indicates for the drainage, which is followed by thoracotomy. Then flail chest. Flail chest is the reverse of the actual respiratory pattern. Usually, when we inspire, then the chest is like move upwards. But when there is a flail chest, the chest moves downwards on the inspiration and moves upwards on expiration. So when this kind of movement is seen, then it is noted that the patient is suffering from a flail chest. The treatment is adequate ventilation has to be given, splinting the area with any sandbag or IV fluid bag, administration of humidified oxygen, fluid resuscitation, and good analgesia. Next come the cardiac tamponade. It could be because of any penetrating or blood injury. The pericardium is filled with the blood from the heart and the adjacent great vessels. So there is interference with the cardiac filling. So once the airway and the breathing is checked, next comes the circulation, wherein the patient's blood volume is evaluated. So if there is any hemorrhage or any major blood loss, it could lead to the death of the patient. So most of the deaths caused are due to the 32 or due to 50 more than 50% of the blood loss within a period of 24 hours. But if there is a loss of 30 to 40%, then there is a chance that the patient might lose his life if at all the immediate care is not given. And in cases of major blood loss, patient can also enter into a situation called shock, which is a clinical state of cardiovascular collapse characterized by acute reduction of effective circulating blood volume and inadequate perfusion of the cells and the tissues. In case there is a blood loss, then immediate like if there is a less than 30% of blood loss, then we can directly start with the infusion of Ringer's lactate solution at a rate of 1 to 2 liters immediately, and then we can look for the patient stabilization. If still the hypovolemia is noted, then we need to start with the blood products. So the clinical signs of this shock could be hypotension, that is BP systolic could be below 70, tachycardia, that is the heartbeat could be more than 100, the patient would feel cold and with a clammy skin, there would be very shallow respiration, but the patient would keep breathing rapid, and drowsiness, oliguria, and there could be multi-organ failure also at the extreme stage. Then if the hypovolemia continues and there is no emergency care given, then the heart rate might be increased 90 per minute, then the breathing rate would fall below 20 per minute, with above 20 per minute, which could be hyperventilated, and it causes with the decrease of the arterial carbon dioxide partial pressure, and then the temperature of the patient would spike more than 38 degrees, or it could go below 36 degrees, and the leukocyte count comes above 12,000 per millimeter cube. And this fourth, the combination of all these four clinical parameters is termed as SIRS, that is the systemic inflammatory response syndrome. So the major signs and symptoms of the hypovolemic shock would be major blood loss. It could be seen as the patient turning pale and the patient turning cold, and the blood pressure would be, if the loss is not major, then the blood pressure would not show much of the changes. But if there is a huge blood loss and patient is going into severe stage of shock, that is class 4, then it could be very low. The systolic pressure would fall more than less than 70, and there could be undetectable capillary refill, and the respiratory rate would be more than 20 per minute. So the immediate goals to manage any kind of hemorrhagic shock or hypovolemic shock would be the stopping the hemorrhage. That is, first identify the site of bleeding. First, we need to check for the patient's bleeding. It could be either intraorally or externally from any part of the body. Then if we are able to locate the site of bleeding, then immediate pressure pack has to be given, and then we have to try to reduce the bleeding. If at all the patient is not recovering from the stage of hypovolemia, and then in spite of pressure packing the bleeding site, we need to suspect for any kind of internal injuries which could be leading for an internal bleeding. So that patient has to be immediately taken up for the investigations to find out for the cause of internal bleeding, and then that has to be surgically intervened and has to be managed accordingly. And in cases of major blood loss, immediately the blood transfusion has to be established and started with the blood products. Then later we have to restore the circulatory volume and the tissue perfusion and minimize the source of contamination. If there are any open wounds which are contaminated, then the wounds have to be debrided and the proper oxygenation has to be established and restore the near normal physiology. So the initial management of a hemorrhagic shock would be the prevention of the blood loss and earliest restoration of the tissue perfusion. The external hemorrhage is identified and controlled by the direct manual pressure, and occult bleeding, that is any kind of internal bleeding, has to be surgically intervened and managed. And then comes the pneumatic anti-shock garment, that is PASG. So when the patient is placed in the supine position, because of no response or any shock, the brain would not respond. And then this could lead for the retrograde flow of the blood towards the normal openings of the body. So it could be through the rectal bleeding or through the abdomen or through the vagina. So this kind of positioning has to be managed by applying any kind of pressure, and then preserving the any kind of blood loss from this kind of vital organs. So the summary of managing the blood loss would be early oxygenation and immediate IV access, and with the infusion of any crystalloids, colloids, or any blood products, and aggressive resuscitation with 11 like the warm saline or Ringer's lactate solution has to be given, and 3 ml of crystalloid for every millimeter loss of blood. And for the blood transfusion to be carried out, the necessary investigations, that as the blood grouping and the CBC, has to be carried out. So the immediate reactions of transfusing any kind of blood products or any kind of colloids or crystalloids could be acute hemolytic reaction or febrile non-hemolytic reaction, anaphylaxis, or transfusion-related lung injury. Delayed reactions could be delayed hemolytic reactions, and immediate non-immunological reaction could be due to any contamination or air embolism. Next, in the ABCD comes the D, which is the evaluation of the patient's disability, and that is nothing but looking for the patient's response and his level of consciousness. So this is the best indicator for the central perfusion and deterioration of the patient's status. We look for the movement of the pupils, and then the Glasgow Coma Scale is checked for. That is the 4 things which we had seen in the previous slide. That is 4, 3, 2, 1. 4 is the best response and 1 is the no response. And then a patient is checked for checked if he is alert on his own, or due to any verbal command the patient remains active, or due to any like stimulating with a painful stimulus the patient responds, or if he is not responding at all. 4 H's which are need to be watched out are hypoxia, hypercarbia, hypoperfusion, hypo or hyperglycemia. Then comes the exposure of the patient. That is when the patient is packed up with his garments or any kind of other coverage, then we can't make out when if the patient is having any kind of blood loss from either of his extremities or any other from the external part of his body. So the patient has to be first shifted to an warm ambient room with an overhead heating, and the IV fluid has to be started, and then the patient's body has to be exposed to check for any kind of bleeding and to stabilize the patient's condition to avoid any kind of hypothermia. Then once the ABCD is done, the ABCD is again re-evaluated. That is, the airway is rechecked. The breathing is checked for the constant breathing of the patient on his own or any adjunct. And then the circulation is managed, the hemorrhage site is managed. And then once the disability and exposure of the patient is done, then we come for the secondary survey. That is the injuries which the patient has got, and it could be delayed to manage the primary survey first. So comes here in the second survey, complete and comprehensive head-to-toe evaluation is done. Then patient's history is taken. He is asked for any kind of any medical history or any drug history or any allergies, and then reassessment of all the vital signs is done. So 6 potentially lethal injuries that should be evaluated are any kind of pulmonary contusions, aortic disruption, tracheobronchial disruption, esophageal disruption, traumatic diaphragmatic hernia, or myocardial contusions. So then comes the history, which is the ample. The mnemonic is ample. So A stands for any kind of allergies, like it could be either food allergies or drug allergies. And then the patient's current medication status. If at all he is having any comorbidities, so patient has to be checked and inquired about his current medications, and then his past illnesses, his previous surgeries and hospitalization history. And in case of females, we need to check for any pregnancy history. And then patient's last meal has to be calculated. And then the patient's event and environment which had led him to the injury has to be asked for. Then once the patient comes, Then this is a protocol which is to be followed when any patient is seen with the injury. So this is a 4-person log roll wherein we need to have a group of 4, wherein one person stabilizes the head, stabilizing the cervical spine as well, and the other 2 try to like immobilize his arms, and the 4th person tries to turn the patient around to check for any injuries on the dorsal aspect of his body, or let it be from his limbs or from his back. So here assessment includes the assessment of any kind of injuries from the face, head or skull, or any in the face we should evaluate for any kind of eye injuries or any blunt injuries and any trauma to the maxillofacial site. That could be either maxilla or mandible, or nasal fractures or zygomatic fractures, or mandibular fractures and positioning of the condyle, his occlusion and teeth and the positioning of the teeth. And then comes the neck injuries, then the chest injuries, and then the other potentially life-threatening injuries are to be evaluated. Later comes the abdominal and the pelvic trauma, wherein investigations would be required, such as ultrasound, MRI or CT, to check for any kind of injuries to the vital organs. And then comes the extremities and fractures, because even the major loss from the extremities from the long bones usually gives more of the blood loss, and it could lead to the patient's death. So I would conclude by saying that emergency medicine is the need of the hour. As a maxillofacial surgeon, we cannot hide away from our obligatory role in acute medicine, and the key to fulfilling this role is optimum training and knowledge. Meticulous and rapid assessment, time conservation, and panic-free logical reasoning and diagnosis is the key to adding up to the patient's life. The World Trauma Day is celebrated on October 17th. Thank you.
Mashallah, Dr. Zayba, it was such a wonderful presentation.
Thank you, ma'am.
Very important aspects of emergency management of trauma patients are very well covered. And now I would again like to introduce our today's speaker, that is Dr. Zayba Noor Nayyer. She has completed her bachelor's from G. Pullareddy Dental College, and she's currently pursuing her master's in OMFS at KLE Dental College. And myself, I'm Dr. Ali Fatima. I'm hosting today's program, and I'm honored to get this opportunity from GDP, and I'm thankful to GDP. I have done my bachelor's from Sri Hassanama Dental College and Hospital, and I completed my post-graduation from Government Dental College and Research Institute, Bangalore. And I am currently practicing as consultant oral and maxillofacial surgeon in Bangalore. So let's move on to our next session, that is question and answer round. So to proceed with, I'll ask the first question. The question is asked by Dr. Gausia ma'am, sorry. Other than GCS scale score, what are the other major things to look into or anticipate in pediatric or facial trauma? Dr. Zayba, can you please take up this question? Dr. Zayba, am I audible? Dr. Zayba?
I think we lost her connection, Dr. Fatima. So we'll continue with the discussion until she gets back to us. I think you should take up the question.
Dr. Zayba has lost her connection, I feel. So Dr. Nadeem sir, our senior surgeon, can we have you please online?
I think I can see Dr. Afzal as well.
Dr. Afzal, can you please take up this question?
Can I ask a question? Am I audible to everybody?
Yes, sir.
Yeah, since Dr. Zayba has lost a connection, the question falls to you, Dr. Ali. See, me as a practicing clinician, I know what is said and given and taught in the slides looks like an emergency care, primary care in the health center or any hospital. So I would put forth a clinical scenario to you.
Yes, sir.
For example, I'm in my practice, evening practice around 8 o'clock. Suddenly a patient comes with his attendee with full trauma, full-blown trauma case of his teeth extruded, bleeding from his mouth, bleeding from his nose, and suddenly come and sits and says, "Doc, do something." So what is the time I should be doing? What are the things I should be evaluating? Should I refer him immediately to the hospital, which is quite far? So what is the primary assessment and care I can give him till I send him to the hospital?
Sir, initially we can, a patient who is bleeding from nose and bleeding from mouth, we can always go ahead and make an attempt to control bleeding. We can do anterior nasal packing for nasal bleeding, and we can do primary suturing to control of the bleeding from the mucosa, oral mucosa. And then, yes, definitely, if we are able to locate the fracture in the jaws, either in the maxilla or mandible, we can do immediate primary stabilization to control the bleeding, and then we can go ahead and refer the patient definitely, or if any oral and maxillofacial surgeon is available near to us, we can call them on consultation and can give them immediate emergency care, and then we can refer them.
No, my question still holds good. What I'm trying to, get the information from you is, see, getting a MAC-based surgeon immediately on your watch is difficult because they're already practicing somewhere away from your town or away from your practice. The hospital ambulances, of the scenario in Bangalore, till they reach your clinic, it might take about 20, 30 minutes. So my question is, as you said, I'm going to suture. See,
Yes.
when you see a lot of excess bleeding and the patient is bleeding to the core, and facial bleedings are, so rampant, the clinician standing there, he himself or herself panics what to do. So the teeth which are extruded, there's lip laceration, tongue laceration. I'm not able to, find out where is the fracture line. So there's a lot of bleeding in the nose. So how do I clean? Do I use any, particular instruments or something? Do I clean that area? How do I go ahead with the primary care so that I, stabilize him for next 15 minutes? What I should be doing? Forget the suturing part, because I don't know where all it is lacerated: lips, tongue, cheeks, mucosa, nose, I don't know. So how do I stop the bleeding? Is it compression or give some medications or topical applications? That is my query.
Yes, sir. Always to proceed to start with the bleeding, we can always give primary compression to stop the bleeding. If at all that is not happening, then we can go along with local styptics which are easily available, and then we can put styptics either onto the gauze piece or cotton, and we give compression on that, and that will initially help in stabilization of bleeding. If at all it is not happening, then this minor arteries will be available with us, artery forceps, that we can see, and we can, if we are able to find out or locate the area of bleeding, we can always ligate it until a primary care we get from a maxillofacial surgeon, or else we can shift a patient to the hospitals.
Thank you, Dr. Ali.
Thank you, sir.
Joined in, I think, if she wants to put in some points.
Yeah, even I wanted to say the same point, that pressure pack and compression gives the best like hemostasis. So no matter what, if we are giving a good pressure pack and holding up, if even a major blood loss can be controlled, at least until the emergency care arrives. That if we are like at loss of any kind of styptics or any kind of instruments, a pressure pack would give or serve the purpose until the ambulance or any emergency care is arrived.
Thank you, Dr. Zayba. Moving on to our next question. Other than GCS scale score, what are the other major things to look into or anticipate in pediatric facial trauma?
The first thing whatever we need to look for is first the airway and the breathing, and also the blood loss, because in kids even major shock can also lead to uh, uh, the brain failure, and the patient might not recover, or there are chances that the patient might enter into a state of coma very easily in case of kids. So first thing we need to establish is the airway and the breathing, and then the circulation. Circulation is nothing but the blood loss. And GCS is all about the patient's response to us, like how the patient is responding, if the patient is oriented or not. If at all he is oriented, then depending on that, we tag the person, and then we kind of take him to the emergency care depending on his severity. But what we look for is the patient's response, as in the airway, if it is established or not. And if it is not, then emergency airway has to be established. Let it be a kid or an adult.
Thank you, Dr. Zayba. Moving on to our next question. How do you recognize airway obstruction?
If the patient's respiration is very shallow and very rapid, and if it is agitated, so that means there is some kind of an obstruction. And also if the patient's chest movements are not normal, and even that indicates for an obstruction in the airway.
So basically this look, listen and feel we are talking
Look,
about.
listen and feel.
Okay. The next question is, which is the most physiological IV fluid and most common fluid given in case of blood loss?
We give Ringer's lactate at the immediate. So if at all we find the signs of hypovolemic shock, then we immediately establish the IV fluid of Ringer's lactate at least 1 to 2 liters, like at a faster speed, so as to recover the patient from the shock state.
Moving on to our next question. What are the adjuncts to primary survey other than ABCD?
What are the other adjuncts?
Adjuncts to primary survey.
Other than primary survey comes the secondary survey, wherein we look for the other injuries in the other parts of the body, apart from the site which had been giving the major blood loss or leading the patient to that severe state. So the other things are to be evaluated later, but first managed after the once the primary site is managed, and then comes the secondary site of injury or the things which can be delayed and can be managed further.
I would like to add on this. Other than primary survey, we could always see into the adjuncts like vital signs of the patients, like blood pressure, respiratory rate, and then temperature, and then ECG monitoring, urinary catheter placement, whether it is required, and blood glass, ABGs, and pulse oximeter. We can always see to check the saturation of the patient. This could be the add-ons to primary survey. Dr. Syed Afzal, can we please have your views on this question, please? Dr. Afzal, sir. I think sir is not online. And the next question is, within what limits we can try to control the emergency care as general practitioners, or how to take a call as a general practitioner, whether to attempt this patient or directly refer to hospital without wasting time?
First, we look for the breathing. If there is no breathing or there is no respiration and the pulse is not felt, then better we do not attempt or waste time over there, and try to call for the ambulance immediately to shift the patient to the hospital. But if at all we find any vital signs, that is, pulse is felt and the breathing is seen, then we can try to just resuscitate the patient until the emergency care arrives. So that is not something which we need to stop at any point of time, but until the ambulance or any hospital facility is arriving, until then we need to keep the airway and breathing patent.
And I think the motto of today's topic for general dental practitioner, why did we select this topic today, is that for general dental practitioners must know at least the initial assessment of the patient and how do we do primary care for the patient. I think that is the motto for this today's webinar. Moving on to our next question. How do we calculate the volume to be replenished?
First, we check for how much of the blood loss has happened. We check it with the patient's the clothing, and also how many of our pressure packs we have used, the gauze and all. Everything is counted and checked for the blood loss, and that is done with according to the patient's body weight, and also the patient's age and build. So depending on the amount of blood loss, we need to check for what kind of blood product has to be given so as to get the early revival of the patient.
Okay. So our next question is, from what age in children Valampati score can be implicated, and below the indicated age, if any, how is the child airway patency assessed? From what age in children Valampati score can be implicated?
I don't know this now.
I have. So inshallah, we'll get back into the literature for these questions and we'll try to
Find out about it.
Search for the answer for this, inshallah. And can cricothyroidectomy be done in children? Is the next question.
No. Cricothyroidectomy is usually contraindicated in kids.
About 6 years of age, we can do it. Do we have any more questions?
We do see.
Yeah, I have a question.
Yes, sir.
See, most of the general practitioners are not equipped or not well versed with the primary care or the trauma care to be given. If so, if we have to refer the patient to the hospital and whatever care which is given at your practice, and something happens to the patient in the hospital, as a GP, are we also held liable for treatment given in the primary care in the clinics before we send them to the higher care center? The question is open for both the moderator and the speaker.
I think in the treatment register, everything would be recorded for sure, but it is not about liability, that who would be held liable if like patient at all loses his life or some complication happens. But if at all there is some carelessness being followed from the person, let it be a general practitioner or the first the person who has witnessed it, then definitely he would be held responsible.
I think we have Dr. Iftikhar also online. He is a practicing advocate also now. Dr. Iftikhar, can you unmute yourself? Can you answer this question, please?
Assalamualaikum.
Walaikum.
I am a law graduate, but not a practicing advocate.
So probably coming time would refer this as practicing LLB.
So, but
can you answer this question, yeah, in terms of
the legal point if you're trying to take? See, it all depends on what the patient's perception is. In case they want to drag you into the loop of the legal complexities, yes, they can. You can't say, okay, I was just a GP and so I just referred. They can question you that because of your actions, if there was any kind of negligence or anything, because you will be the first person who would have been there. Whether you have, there was any negligence from your side or not, first you'll have to be ruled out. So obviously you'll have to defend yourself to get out of the legal loop. Other than that, depending on the complexities, yes, the hospital where the patient is taken off, they'll be the major people who have to answer any kind of issues, legal issues.
Okay, Dr. Iftikhar, can we put our foot down and say, okay, I'm not trained to do this primary care or whatever the initial care to be taken. I cannot do this. Please take him to the hospital right away. Can we have that authority to tell the patient or the attendee?
Yeah, I mean, if they've approached you and if you're not, if you're not really well versed in it, yes, you can always tell that. There's nothing like, unless according to your, if you're like whatever your BDS or an MDS, and what does your degree allow you to do, and or they say like, fine, okay, this much you can do, this has to be done, this is required, then yes, you have to do it. You can't say no, I can't do anything. But say, for example, like we have Dr. Ali Fatima and Dr. Zayba Noor and any of the maxillofacial who are trained, if at all, in their MDS, that they have to do this primary procedures, maneuvers, which probably other BDS may not be, what do you say, qualified. Then yes, they have to say, they have to do such thing. They can't say, okay, I can't handle it. That's what my perception is on this.
Right. Thanks a lot. Yeah.
Do we have any more questions?
Yeah, I can see Dr. Abrar's question on the chat section, Doctor.
This is answered.
I asked the question.
I have one question. Dr. Zayba, you mentioned that in case the patient, you can't see any vital signs, you need to immediately shift the patient to a hospital rather than wasting time by doing any kind of maneuvers. Now, what would you do? You would wait for the ambulance to come, or you immediately shift it probably by in your car or anything like that? What are you supposed to do?
So it would be me, then I would look for the thing which would like get him to the hospital at the earliest.
Yeah, so by your own private car or something, rather than wait for the ambulance.
Rather than wait for the ambulance, because it could be a rural area or it could be an urban area as well. So if we are beyond the city limits and we could not wait for the emergency ambulance or the hospital facility to arrive, and we have got our own means of transportation, then better we try to take him immediately rather than waiting. And because as I already spoke about the golden hour, it's not suggested to keep on losing on minutes or even the seconds of the patient's life.
So nothing need to be done to
we can try to resuscitate the patient if at all we are trained for it, because it is again a complication in itself. Because if it is like not well trained or not at all trained, then we might break the patient's ribs as well, which would give him another injury or complicate the situation. If at all we are trained for, then we can give. And there is another thing called as the mouth-to-mouth breathing. So if we want, we can even try giving that. At least try to resuscitate the patient on the way to his hospital.
Okay, thank you.
We have one more question. How do we decide for endotracheal intubation? Like, what time is the correct time to start endotracheal intubation?
Endotracheal intubation, when the orally or nasotracheally we are unable to establish, then we need to try not more than 30 to 45 minutes. And then we need to start up with the endotracheal intubation, that is either through cricothyrotomy or the tracheostomy. 30 to 45 minutes is the time we need to try, and not beyond that.
To add on to this, I would like to tell if there is inability for the patient to manage airway on its own, or he have lost airway reflexes, or oxygen saturation is going below, we can always take for endotracheal intubation. Okay. I guess those are the questions from our participants.
Wonderful presentation from both of you all, actually. It was good learnings, a lot of new learnings from both. And I know a hectic time of the year, but yes, it was good learning from both of you. I thank you for the good presentation. I think we can go for the conclusion.
Dr. Zayba, would you like to give any message?
All I want to say is, like, if at all we come across any kind of scenes, rather than running away from that spot, better we get back there. And we, being at least doctors, we hold that responsibility to at least address the patient. If at all we are unable to do anything, we can at least try to arrange the service for the patient so as to take him to the nearest hospital or give him the emergency medical care, because every life counts. We do not know what kind of importance that person, let it be a aged person or a young patient, still every person holds their importance in their own life. So we being doctors, we need to be responsible, and rather than running from the situation, we need to act or take some action against to save anyone's life.
I would like to give a take-home message for related to today's topic. That is, like, as we all know, prevention is always better than cure. So I would insist on carrying on with protective headgears and seat belts to prevent physical injury, which will ultimately lead to mental injury to ourselves, our families, and our loved ones. So always prevention is better than cure. Jazakallah one and all.